Hello all, let's learn about how to have syndrome-based antibiotic prescriptions. Let us understand the key concepts. How should there should be syndromic approach in infectious diseases? Let us first have primary organ involvement understanding. What are the possible pathogens? What are usually the natural flora? Usually from the natural flora of the system or published literature on epidemiology of the organs. And based on the organ involvement, understand the host factors. What is the age? What is the immunosuppression or competence status? Is there any exposure to multi-resistant organisms or healthcare organizations? Any specific interventions are being carried out on the patients? Understand the choice of the empirical therapy. Or what is the potential list of pathogens? What is the risk of multi-resistant organisms among them? What are the single and multiple antibiotics to cover the pathogens? Understanding all these factors will help us to have an easy syndromic approach to infection disease. Also, one should remember while prescribing antibiotics, what are the indications for the use, whether it is empirical or prophylactic or definitive, what is the route of administration, dosage, duration, frequency, adverse effects, interactions, complications, and others. If a drug was on the result list, then what? If there are the drug combinations is required, whether it was approved by microbiologist, was cultural sensitive performed, what are the guidelines available. These all the factors affect the antimicrobial prescribing. So what we should understand or know to prescribe this, to practice this syndromic approach. There is empirical antibiotic policy. Primary organ system involvement is necessary to understand. Whether it is CNS or brain stems or brain infection, we face, for example, brain abscess. Then what are the potential pathogens in the user settings? What is the overall flora? What is the sinus infections? Whether it's the gram-positive, cocci or anaerobe and other such things needs to be considered. What are the potential pathogens in specific conditions like traumatic or post-operative? Then it can be either gram-negative bacilli or MRS or fungi. Then antibiotics, I understand what are the antibiotics that will cover these pathogens, ceftriaxone, metronidazole, and others. Similarly, if it has been a CNS and brain infection like meningitis and infectious, then potential pathogens in usual settings is gram-positive cocci or viruses or tuberculosis and tuberculosis infections. In immunosuppressed status, it could be cryptococcus, toxoplasmosis. So currently we have the antibiotics lined up such as ceftriaxone, oxypotassium. Then if it is acute respiratory infection, we have GPs and viruses, H influenza are typical amongst pathogens. In immunosuppression, we have pneumocystis carinii pneumoniae and other such. We had antibiotics such as ceftriaxone, azithromycin, and scotramazole for the same. Syndrome-based approach it is imperative to understand the conditions, the first choice antibiotics, the alternate antibiotics, and the comments given. You can refer to the ICMR guidelines for the same. For example, the type of community acquired pneumonia. If it is outpatients with comorbidities, the preferred is coamoxicillin, alternative to macrolides or cephalexin. Comments beta-lactam preferred or the macrolides due to high prevalence of macrolide in the Streptococcus pneumoniae in India. We have to always have national antibiogram as the base when we prescribe antibiotics on an empirical basis. Antibiogram helps us to understand the resistance pattern and the antibiotics that will be effective against those prevalent pathogens. Specimen-wise breakup the isolates linked to the clinical syndrome. For example, for blood or urine or lower respiratory tract, what will be the common pathogens, and that will help us to understand the diagram, and on the basis of which we could have the antibiotics on an empirical basis. When we have the top isolates for a particular organ involvement, link it to the risk assessment, the severity, whether it is E. coli, whether it is Pseudomonas, Streptococcus, and others, and accordingly proceed for the antibiotic selection. Country-specific antibiograms are available. You can refer to the country-specific antibiogram, link it to multi-drug resistant organism cover for the syndrome under consideration. 30 to 40% of the patients with culture-negative sepsis will have non-infectious etiology. Sepsis on the basis of suspension of infections needs to be considered. Many conditions can mimic sepsis, such as cardiac disease like heart failure, or sinusitis like seizures, or gout, or adrenal insufficiency, drug overdose, and other such conditions needs to be considered while treating the patient with sepsis. So make a syndromic diagnosis, organ system-wise diagnosis, usually sometimes as occult sepsis or tropical sepsis. Consider the pathogens involved, the host status, the immune status, age, and other such factors. Then review. Review the local antibiogram may be relevant. It is may be relevant to understand the most prominent pathogens causing the syndrome and with the risk of multi-diagnostic organisms. Then finalize the antimicrobial combination that will cover these pathogens while we await microbiological confirmation. Clinical diagnosis is the starting point and most important part of stewardship program. Understanding of the risk factors is imperative. And the ICMR guidelines, so the national and the global guidelines are then available for us to pick up the list of pathogens. Local hospital or ICMR antibiogram can be used to predict the prevalence of antimicrobial resistance. Select the antibiotics most suitable for the potential pathogens and its site of infection. That's all. I'm thanking to all of you. Thank you.